have him with us today, and the title promises to be a very, very nice talk, which is, Are Our Predictions Fair? Assessing and Addressing Algorithmic Bias in a Transdiagnostic Risk Calculator for Psychosis. So, Dom, I leave it with you for the rest of attendance. You may like to know that you will have some space for questions and answers by the end of the talk, and that this talk is going to be recorded. So if you have any inconvenience on that, please put it on the chat. And yes, so that's everything. Dominic, really looking forward to hearing you. Thank you.
Thanks so much, Raquel, for the invitation, and thank you everyone for coming. It's great to see so many people in the room. So I'm going to be presenting some ongoing work today. So this is all quite fresh off the press, including some analyses that I ran last night. So, really would be open to any kind of feedback from people at the end of things we can do to improve this as we go forward. And kind of really what I want to get across today is that accuracy alone isn't enough for ethical prediction. So, in precision psychiatry, we're aiming to use data, usually healthcare data, to inform clinical prediction models and improve people's care. But we want everyone to have this opportunity to benefit from this kind of approach. And certain subgroups, maybe different genders or minority ethnic groups, are associated with poor access to care and poor outcomes in mental health care. And the data that we use captures these disparities, and therefore the models that we train on these data could perpetuate these disparities and these biases. And overall, any prediction model aims to improve care, and any paper that we typically publish will show that maybe this model is doing so at the population level. But there might be differences in subgroup performance that we might not be capturing with our kind of typical analyses. And this bias can come into our models at different stages. So this was a paper published a few years ago, kind of outlining the different types of biases that can enter your model at different stages. And I think kind of the one that we're going to be talking about a lot today really is kind of, in this model development stage. I'm hoping you can see my mouse. Essentially, we're going to have these minority groups. So, for example, ethnic minorities that are going to be present in kind of small proportions compared to majority groups. And it might be that, we have kind of these labels might not be kind of evenly distributed across all these ethnic groups. And that means that the kind of relationships that we map between these groups and the outcome might be skewed depending on how we progress through our modeling. And I published a review last year, and kind of towards the end of this kind of mentioned that, individuals from these subpopulations might be underrepresented, and therefore the models that we develop may be less accurate, and they might kind of entrench existing biases and unfairness. It's something I've been thinking about a lot, and kind of since publishing that paper, I've been trying to kind of put this into action, and that's what I'll be talking about today. And part of what inspired this was kind of coming across this paper that was published in Science, I think in 2019, that I came across, which was essentially kind of confronting a problematic model that was developed and implemented. And this model was used to kind of predict kind of illness and sickness within populations. And what they used as a proxy measure of this was, because this was a model developed in the US, they used healthcare costs. which seemed like a sensible approach, but not thinking through that this also relates to the kind of insurance that people are given. And white patients were typically more well off and therefore had better insurance and were spending more money on healthcare. So as a result, setting a cutoff of healthcare costs to represent illness meant that Black patients were considerably more unwell than white patients at that same kind of threshold. And I've been involved in, a program of work that I'm going to be talking about today, which as a clinical use case. So developing, validating, and implementing a clinical prediction model in psychosis. And really, I want to avoid a situation where we actually, implement a model in real world healthcare, and it's going to be at the detriment of the patients that we're trying to help. So I'm going to outline the model and kind of the use case for this and what we've done so far, and then kind of explore a few different ways of assessing algorithmic bias, kind of both kind of some failings of my own kind of over the course of trying to put this piece of work together that I hope is going to be informative, as well as kind of a way moving forward that I'm hoping will be quite useful. And then also a few different ways to try and address this bias, applying it to the clinical use case that I'm describing. So, I really work in kind of psychosis prevention and detection, which is really the first rate limiting step. So if we're poor at detecting people at risk for psychosis, we're not really able to prevent the onset of the disorder. And ideally, we'd be detecting people before the first episode of the disorder. We have a clinical service. So there's one in South London and one in Oxford that I work with that try to capture these people early, provide preventive treatment, and prevent the onset of the first episode of psychosis. We did some work a few years ago where we looked back at all the first episode cases within South London, and only 5% had been detected early by our preventive services. So there's a lot that can be done to try and address this this kind of missed opportunity, really, where we could potentially give people preventive treatment earlier. And even if we're in those people we do detect, we had a model that was able to 100% accurately predict who's going to develop psychosis and had a treatment that will prevent 100% of psychosis cases. Without good detection, will only be really helping a small proportion of the population. So to try and address this, we wanted to use kind of routinely collected clinical data in the electronic health records. So we use a Cox proportional hazards model to predict the risk of psychosis onset within 6 years of receiving their first diagnosis and secondary mental health care. So these are people who maybe they present with anxiety, they get diagnosed with an anxiety disorder, and then several years later progress to psychosis. So these are the kinds of people we're trying to detect earlier and get them more appropriate care. And at the time, we only really had access to structured data. So we chose 5 routinely collected predictors that were defined a priori based on kind of meta-analytic evidence, and really just what was available in the health records that were going to be completed by clinicians regularly. So we just included age, gender, age by gender interaction, ethnicity, and the first diagnosis that people presented with. So this was implemented online at psychosisrisk.net, and we've externally validated it in a few NHS trusts in the UK, and a large-scale validation in the US. And also, this was the first model in psychiatry that was tested for implementation in the real world. So we used this prospectively for a year, and our main outcome was, whether clinicians kind of responded to the recommendations of this risk calculator and were referring people, and got high acceptability at around 84%. We've since kind of tried to refine this model. A lot of this benefits come from integration of natural language processing, or NLP. So these are algorithms that are able to extract mentions of symptoms and substance use from the clinical notes and letters in the health records. And this allows us to kind of quickly screen large volumes of text data and identify useful clinical information to be used as predictors in our model. So when we published this paper a few years ago at the time, there were 14 of these NLP predictors that had over 80% precision and we thought were kind of reliable enough to use in our model. So we added this to our original base model and also integrated lasso regularization to drop any non-informative predictors. And this substantially increased performance. So whereas our Harold C statistic was 0.79 in the original model in external validation, this increased to 0.85. So that's my kind of quick overview of, I think, the main work that we've done that kind of informs kind of the algorithmic bias assessment that I will be talking about. And really the aim of this talk is to really say, we've got kind of some good population level performance, but is it fair? And in particular, what I was interested in is that, we had these 5 predictors, which, one of them is ethnicity, and if we're adding in these extra NLP predictors, is that adding sufficient information that then means it also, as well as increasing population level performance because of that reduced reliance on the ethnicity variable, does it also improve the equity of performance? So the plan is here to assess algorithmic bias within the original model and the NLP refined model. And I mainly looked at this in terms of gender and ethnicity. First question, I guess, is how do we assess algorithmic bias? The Wellcome Trust published this report last year, which was essentially a worked example of how to assess and address algorithmic bias within a clinical prediction model. And their kind of focus really was on equal opportunity difference, kind of comparing true positive rates on the basis of ethnicity and kind of other kind of subpopulation differences, so all categorical. And kind of similarly, this paper was published in BJ Psych last year, looking at algorithmic fairness across a bunch of different models developed using the Pronia data set. And they kind of used a similar kind of fairness index kind of based on classification performance. And, in our model, as I've already kind of presented, our model isn't really a classification model. It's, our outcome is discrimination, which is kind of looking at a continuous outcome, which is kind of risk of developing psychosis rather than a yes/no. So I kind of looked at trying to adapt this for that. So I initially just tried to kind of follow it quite similarly. So applying the coefficients from the published model onto the original external validation data sets, essentially reperforming the external validation from the original papers, generating individualized risk estimates for all patients in the validation data, and then kind of filtering the data set for each subgroup and generating the discrimination metrics and repeating. So you'd have a C index for men and women, similarly for white patients, black patients, etc. So in terms of the data that we're using, so this is South London and Maudsley. The original model development and validation was split across the different boroughs that we have in South London rather than random selection. So the model was developed in Lambeth and Southwark, and then validated in Croydon and Lewisham, For the NLP model, there was additionally anyone in Lambeth and Southwark who, but basically the idea was to just, retain the same development sample. There were some people who opted out of the data set in the meantime, which is why the numbers have gone down. But anyone in Lambeth and Southwark who kind of started receiving care after 2017 is included in the validation sample for NLP. So I've essentially just replicated these validation samples and development samples for all of the analyses I'll be presenting today. Just to kind of characterize the kind of differences between subgroups, this is a Kaplan-Meier plot showing time to event across males and females, and there's a very small kind of higher cumulative incidence in men versus women. Then kind of going to our kind of subpopulation discrimination performance, there was kind of no significant difference between men and women. So the golden line is kind of the overall performance, and then it's stratified by males and females. So there's some kind of potentially minor differences here, but they're kind of crossing that kind of overall performance line. Moving on to ethnic groups, there's a lot more variation in terms of cumulative incidence. So this is kind of highest in Black patients, then Asian, then other, and then mixed and white patients are quite similar. And kind of similarly, we see some differences in the original model, but all of these confidence intervals cross the kind of null effect line, with the exception of white patients where the model is performing slightly worse. And then kind of in the NLP model, kind of similar kind of pattern where you have Asian, Black, and other patients kind of crossing this null line with kind of lower performance in mixed and white patients, but there's a lot of variability in the mixed patients, which is similar to original. And the reason I'm kind of rushing through these results is because I realized that I don't think this is a very good way of measuring bias. And the reason for that is because I tried to mirror the kind of welcome recommendation and what was done in that previous BJ Psych paper, but these were all classification problems. So you have a control group and a case group, and you're just drawing a line between them, and you're looking at accuracy of kind of assigning those groups. Whereas the model that we've developed is more about discrimination. So we are trying to predict the percentage of risk that someone has of developing psychosis over 6 years. And ideally, we'd still get this pattern where we're getting this nice dividing line between case and controlled. But really what we care about is that we're accurately predicting the percentage of risk, and we're hoping that people kind of fall along this line quite well. And I think kind of what we're characterizing here, we're seeing that there aren't that there isn't any bias within these different ethnic groups. Is we might be getting a situation like this where we're kind of getting our percentage risk along the x-axis here. We're getting maybe a good distribution in white patients, but there might be skew within different ethnic groups. So it might be that Black patients are generally, their risk is overestimated, and Asian patients are generally underestimated. But because with a Harrell-C statistic, what you're doing is you're picking out the case and control of your data set at random and seeing the proportion of the time where the case has a higher score than the control. We might be seeing, we're only comparing within these groups. So we're looking at, are we predicting Black patients as having a higher score than Black controls, but we don't know how the model is performing for them compared to white patients, for example. So basically, there are two major limitations that I'm going to try and address here. So basically, fairness is only measurable in what I've done so far in relation to the data we have available. So if Black patients are being overdiagnosed with psychosis, Sorry, this is something very different to what I meant to write. So ignore what's on the screen and listen to me. So, if we are kind of systematically overestimating risk in Black patients, and we're only looking at, these metrics within Black patients, then, we're not going to know whether we're actually performing worse in that group because we're not comparing them to white patients. So instead, what I'm proposing is if we kind of are looking at, trying to move these different ethnic groups onto this graph where we have the percentage of risk, so our risk estimate on the x-axis, and then the caseness on the y-axis. So 0 at the bottom, meaning they're not going to develop psychosis, and 1 at the top, they are going to. For each individual, say for this person here, their caseness, we're going to measure as 100%. They've got a risk estimate of 70, and then we calculate an individual prediction error for each patient in our data set. So similarly, for the controls, we do the same thing. So if we had the same risk estimate for someone who didn't develop psychosis, they'd have a minus 70% prediction error. So the other thing that we also can address here is that we weren't able to really consider intersectionality. So that the deeper you go in trying to combine gender and ethnicity, for example, if we wanted to see specifically how our model's performing in Black women, we'd have a smaller number of participants, and particularly because in the Harold C statistic, you need cases and controls. This kind of will get even more noisy the kind of smaller your group sizes are. So essentially for each model, we've calculated this individual level prediction error, and then we've fit a linear model using gender, ethnicity, and their interaction to predict the prediction error, and extracted coefficients associated with these subpopulations, basically showing what's the average prediction error we see within this group compared to white patients for ethnicity, males for gender, and then white males for the interaction, and see whether they're significantly different and what the kind of magnitude of effect is. So I'm going to present the ethnicity results first. So the original model results are in red, and the NLP models in black. Those dots that are filled in are statistically significant. And we can see that the model generally is kind of overestimating risk across all ethnic groups in the original model compared to white patients. And this wasn't seen in the previous analysis when we were just looking at the Howard C statistic. This has improved slightly with the NLP model. So Asian and mixed patients are no longer statistically significant from white patients, and the kind of magnitude of effect looks to be slightly reduced. For gender, similar to what we saw before, no significant differences for female patients. There's also other patients here who didn't indicate that they were kind of within the gender binary. However, these were a very small population, so the 95% confidence intervals are extremely wide. But that's something just to consider going forward. And then for the interactions, we see kind of significant overestimation of risk within Black women compared to white men, but no other kind of significant differences in terms of the interactions here. And that was present in both models, and the NLP model doesn't seem to have resolved this bias here. So there are some biases inherent in the model. I think, trying to interpret what this means in practice. So, it's going to be, so on the basis of, Black women here, it's maybe a 1% increase compared to white men. So I think the absolute metrics are quite small, and that's maybe something that we should discuss about, how large a bias is one that we ethically need to act upon. But because of the numbers statistically significant as like to consider. So because there were these significant differences, I thought, it's not really going to be a complete project until we try and reverse these and address these biases. And there are a few different ways that are recommended in the literature of how we can try and address these biases. So one of these, and this is something that's come up a lot in kind of publishing these previous papers from reviewers, particularly American reviewers, who basically don't think that we should be using ethnicity in clinical prediction models at all. Whereas my argument has always been that removing that predictor doesn't necessarily remove the bias, as it might, better model those kind of real, discrepancies that we see in real life. So I wanted to test this to see whether, removing ethnicity would improve these biases that we see. Then trying to add in interaction terms. So does kind of interacting ethnicity with all the other predictors in the model increase our kind of ability to kind of better map kind of individual risk within ethnic groups. Random oversampling, so trying to upsample patients from minority groups. So is it just the case that it's a sample size issue, and by upsampling patients from minority groups so that they're equal to white patients, you're then getting a more representative model? And then finally, stratified recalibration. So trying to apply logistic recalibration within each of our ethnic groups to try and bring our predictions kind of closer to kind of the observed risk that we see. So we've got the kind of original plot on top, and this is now just restricted to significant differences. So first, adversarial debiasing, it changed the pattern of biases, kind of exacerbated some biases, introduced some new biases. So people from other and mixed ethnicities who are also female have now had significant prediction errors compared to white men, which wasn't apparent in the original model. And while we no longer get the overestimation of risk in Asian and Black patients, we now get a significant underestimation of risk. And, I think there's a debate here, and something I'm going to touch on a bit later about, which option is better, because it might be that underestimation of risk is desirable in a certain setting, but maybe overestimation of risk could be beneficial in others. Interactions kind of similarly kind of exacerbated some effects, reverse direction of others, but doesn't seem to have resolved anything particularly. Same for random oversampling, and same for stratified recalibration. So none of these methods really worked well, and I think part of the reason might be just because of the kind of small absolute prediction errors that we see. So trying to correct something that maybe is too small of an error that's just leading to more noise rather than anything resolving. And maybe it's just kind of the sample sizes of tens of thousands that are leading to significant effects, might be something to consider. So I was thinking, what else could we do to try and address these? And one thing I was thinking about was post-implementation, if we're making a clinical decision on the basis of a threshold, at the moment, we're going to be applying the same threshold for all patients, but we could also adapt these. So, basically selecting on the basis of what's the highest balanced accuracy, for example, within each group, and using that to kind of inform, how we implement post hoc. So just to give an example here, so on the top we have kind of an overall threshold being picked for all patients, and then applying that threshold for Asian and Black patients. And we're presenting the specificity here on the y-axis. So here we have quite high specificity in all patients with kind of substantially lower specificity seen when applying that same threshold to Asian and Black patients. But what happens when we adapt this threshold? So we have slightly higher thresholds for Asian and Black patients that kind of fits better. We then increase the balanced accuracy of the model in prospective use, which if we'd used that same threshold for everyone, would have been a detriment to some of our patients. And yeah, this is just showing the balanced accuracy. So kind of just showing that there's kind of very limited change for white patients when using the same threshold or this adapted threshold, but there's kind of a significant increase, particularly with the original model, less so for the NLP model. So I'd say that these are kind of relatively small increases, but I think could make a substantial difference when implemented, particularly when you're screening thousands of people. So those are kind of my main results. I'm looking forward to discussing. And I think kind of what I've learned throughout this process is that I don't think there is a blanket fix for all models. So any solutions that we have are going to be very model dependent. And unlike what my reviewers have been suggesting, removing variables like ethnicity don't resolve these biases and may just kind of introduce different ones. And adjusting clinical decision thresholds may be a very simple and easy way to try and address biases, at least in our model, but might be a consideration for other people as well. Some kind of future questions that I'm looking to investigate. So are the patterns that we see in this external validation the same as what we'd see if we externally validate elsewhere? Are these patterns consistent? And how do these biases change over time? There's increasing discussion about temporal validation and how kind of in clinical settings may change over time. So how do these biases change as populations and clinical settings change? How does this look with more complex prediction modeling methods, so either machine learning methods or dynamic modeling methods? I guess, can we try and make a more systematic approach for assessing algorithmic biases that kind of fit into kind of gold standard guidelines for clinical prediction models that kind of result in discrimination calibration being reported compared to classification methods? And I guess where I'm going to leave you on is I think that I've just presented a lot of uncertainty. And the question really is, how can we ethically choose which model works best? It might be that we need to use different models for different populations, but also maybe different thresholding. But I think these solutions also need to be setting dependent. So going back to our kind of US example at the beginning, I think if we had a model that was over predicting risk in Black patients and we were implementing it in the US, it would mean that maybe their healthcare utilization might go up, their insurance premiums might go up, and this might disadvantage those patients. However, in the UK, if we were to implement the same model, it might mean that more Black patients will get access to preventive care free of charge. And that might be kind of considered a way of kind of algorithmic reparation for the kind of poorer equity and access to care that Black patients have historically had in the UK. So really, I think whenever we're thinking about this, we need to think about what the impact of implementing our model is on these different groups and how bias weighs into that. So really, we should be measuring these biases and considering their impact before implementation. And this is one way I'm suggesting that we could do this, but I'd be interested in any thoughts people had of how we can improve this further. Okay, and that's everything from me. Just want to thank everyone involved in this project, although I think I haven't really sent around the draft yet, so this is a lot of the first time some of these people are seeing these results. But yeah, thank you very much and looking forward to answering some questions.
Thanks very much, Dominic. It was excellent seminar, excellent work. Congratulations a lot for this. So if anyone has a comment or question, please raise your hand. I can see there is a question already in the chat, so maybe we can start by this one. It's by Jarek Verhis. So for anyone who wants to look at the seminar, is showing the study by Overmeyer. Thanks very much. And then the question was, did you also look at the interaction of gender and ethnicity, like performance for woman of color versus white woman? Good question.
Yes, so I think that might have been sent during my kind of initial analyses, which didn't look at interactions, but in all of the kind of prediction error analyses, we did look at those interactions. And I think in the kind of original analyses, the only kind of significant difference we saw was for Black women specifically having kind of overestimated risk compared to white men.
Is this answering your question, Jarek? Yes, perfect. Thank you so much. There is a second question by Lorik Ferrat. So thank you for your talk. Have you considered people from admixture ancestry? And how would you tackle unfairness for people from multiple ancestry who are more and more present in the population? Sorry if you talk about it. He had to go. But anyway, I think it's very interesting as well because the admixture is like a continuous variable, right? It's a percentage of different ethnicities for a single person. So that's an interesting point as well. Have you thought about how you could study this association of, the bias associated?
Yeah, it's a very good question. So I think currently the way this is represented in the data set we're using, so we just have kind of one category for mixed ethnicity, and there are a lot of different ethnic kind of combinations that could be present within that. Very aware of this because I'm of mixed race myself. So I think that's a very good point in that we're kind of collapsing a lot of different kind of ethnic groups together within that category. That is something that we could look into further. I think the only caveat being that, it's kind of our smallest group already, and the more we separate that out into subcategories, the less powerful our analyses will be. And we won't know whether, because I think that, as I pointed out, the kind of biases we're seeing are already very small. And my worry is like how much if we're kind of separating it down further, it might be the case that if we get a non-significant difference, is that just because we've reduced the sample size down rather than, we're kind of seeing that we've got a lack of bias within these populations.
Thanks, Dominic. I think then Jarek has another question. Please go ahead.
Indeed. Can you hear me clearly?
Yes, we can hear you. Thank you.
Perfect. I might have missed a beat on the adaptation of thresholds you did, but if not, did you look at the the clinical outcome, the steps that were taken by the users of this system? So what did happen once a new patient was screened by the system, and did it between the groups vary what next steps were taken, like medication or introduction to early treatment or whatever? That could also be one way bias sneaks into our predictive systems by the way the advice is acted upon, differing between the groups.
Yeah, that's a really good question. So no, we haven't looked into that as of yet. I mean, I guess that could potentially explain, why we're seeing these biases and the relationship between, these different subpopulations and the outcome. I think I'm not sure if this is what you were saying, so ignore me if it's not. But so this was all kind of retrospective data, so this isn't from our kind of prospective implementation study. So no action was being taken on the basis of any of these thresholding. But it still might be interesting to see, what kind of treatment pathways these people were experiencing after the point of prediction. But yeah, great question, and thanks for coming. Nice to see you.
Thanks, Dominic, for your answer. Andrew, I think you have a question as well. Please go ahead. Thank you.
Hi there. Thanks. That's absolutely fascinating, and really particularly good to see it at like an early stage as well. I think it's really nice to see this before everything feels like it's 100% settled and the paper's ready. So thank you very much for bringing that. So I wanted to ask, and apologies if I missed this, but when you tried the interventions to reduce the bias, did they make the overall sort of model performance substantially worse, or was the effect relatively modest? I mean, obviously we saw the validation performance in the individual sort of subgroups, but was the total performance worse?
Yeah, that's a really good question, and it's something that I thought about last night, and I didn't have time to check, and it's something I should have checked throughout. No, I don't know. I think for some of these, I wouldn't expect the overall discrimination performance to change, because it's kind of more, relative changes within the groups rather than overall performance changes. But for others like, the random oversampling, for example, that could lead to some kind of overall decline in performance, as we kind of expect from those kinds of approaches. And I think, it opens a very interesting ethical question of whether, you're getting a model that's more equitable in terms of its performance, but maybe performs slightly worse on average, and what you kind of do in that context. So yeah, definitely something I will check.
Thank you.
Thanks, Andrew, for pointing this out, which is an important fact, actually. And Gordon, please go ahead when you want. Thank you.
Hi, thanks for the talk, Dominic. That's super interesting. Do you have a sense at all of how much case mix might affect this sort of measure of prediction error that you've got? Because it's sort of, I've seen literature which says that case mix can affect the C statistic, and I don't know, the Breer score, which I guess is also based on prediction error. So if you've got higher prevalence, your Breer score will be different than when a model's applied in a lower prevalence setting, even if it's a perfect model. And I wonder whether this could affect this sort of error metric you're using as well. So even if your model is actually unbiased, you might be seeing differences in model performance just due to the changes in prevalence that you see within these different groups. And this is something I've only read like a little bit about, and I seem to come to the conclusion that like calibration's less affected by this than other measures, but I don't know if that's also true.
Thanks, Gordon. It's a really interesting point. And I guess if that were the case, then we would see the most bias in those groups that have the kind of most divergence from the overall incidence curves that we showed. And it does look like that is the case. So Black and Asian patients were the ones who had the kind of most divergent Kaplan-Meier's compared to the overall. So it might be that you're right in that we are just mapping kind of differences in observed risk rather than any actual biases. Unfortunately, I can't really think of any way to kind of resolve that other than just acknowledging that as a limitation. But I guess it's just something to bear in mind kind of when assessing biases in these ways. Unless you've got a really smart way to resolve it off the top of your head.
No, I think I guess there's a bit of literature on sort of how different performance metrics work in different like change with changing case mix. And I've seen things where people have suggested like weighting populations, so you sort of have the same prevalence in all populations, but this is, I don't know if this would make sense in your setting. And I guess the other one would be simulating data that has different case mixes and seeing how you're, like if you simulate data for what you know is the perfect model because it's simulated data, like which performance metrics don't change because of case mix and which ones do. It would be the only other way, but I don't know. Yeah, no, I don't know the answer.
Sounds like another paper.
Thanks, Gordon. We have another question by Jose Benitez Aureolas. I think that you already asked the question in the chat. I was about reading it, but if you want to formulate yourself, it's absolutely fine. Go. Thank you.
Yeah, thank you. And thank you very much for this talk. This was really interesting. So yeah, it's just the question that I had written. It's more of a clarification, but I think I missed it at the start. But what is the prediction error that you sort of compared in all these plots?
Yeah, let me get my slide up again because I think that'll be more helpful than me just chatting. Where's the slide? So essentially, we're taking the kind of predicted risk estimate for any patient, and we're considering, cases as having a score of 100, controls as 0, and we're just calculating the kind of difference in kind of predicted and observed risk. So yeah, generating a kind of an individual variable for each patient.
Oh, okay, thank you. One sort of, it's not really a follow-up question, but it's sort of a small thing. Have you thought about, since you're using Cox models, have you tried sort of stratification in the survival curve? Just because I'm thinking that in a way, the one big assumption of proportional hazard model is that everyone has this one survival curve, which since probably most of your population is white, it's going to be whatever the white population survival curve is. So I'm thinking if maybe that's one of the causes for.
Yeah, that's a good point. I think yeah, that would be worth trying. I think I've tried to do this kind of at a later stage by doing this stratified recalibration, but I think that would be probably a more effective way of doing it, is just moving it a bit earlier and doing the stratified Cox. So yeah, thank you for the suggestion.
Cheers.
Thank you so much. Is there any other question, comment? We still have 9 minutes to go. If someone else wants to add something, we have time. No. Okay, Andrew, please feel free.
Sorry, one more. So this is a bit speculative, but so in MRI, one of the things we sometimes do is to residualize for things we're not interested in our features. And I'm just wondering, make it a bit more concrete, we might remove, say, total intracranial volume, the linear effects of total intracranial volume or of gender or something like that from our MRI features before running the prediction model for disease. Is that equivalent to any of the manipulations you've done for fairness, or is that something different? And do you think it might work or might help develop a model that could be fairer?
So essentially, like regressing ethnicity out of all the other predictors.
Yeah, exactly.
So we haven't done that directly, although I wonder how similar that would be to the kind of adding in the interaction terms. I wonder if it might be cleaner to regress it out, just because then it reduces the feature space as well, which could also be a reason why maybe it's not performing as well. So yeah, we could try that.
Well, if you do, let me know how it goes, because I'm interested in how that works as an approach.
You might have solved it, Andrew. Who knows? I'll let you know.
Oh. Fingers crossed.
Thanks, Andrew. Nice addition. We have 7 minutes now. Anyone else? One final comment, one final question? I was just thinking. Oh yes, sorry, Joy answer has a question. Thanks, Joy. Please go ahead.
Hi, thanks, Dominic. It was a really interesting talk. And I've been discussing some of these issues with Ben Perry myself recently. I was wondering, so the bias, right? It's intrinsic to the system, right? So the model is just a mirror of that. So I tend to think the same as you, that attempts to model this out just won't really work. So I come to the same conclusion that altering the threshold is perhaps one of the most practical solutions. But I guess at the level you mentioned is still applying a threshold on average for a group, right? So like a single threshold for Black women, say. And so in practice, I wonder if the best approach would be to use an individual threshold based on the individual's preference for weighting their risks in discussion with the clinician. Whether that would in practice handle the bias, I'm not sure, but it feels like the best way to use the model. And I guess I wondered, your plots at the end that were kind of rock plots, I wondered if you'd consider plotting decision curves of your groups and maybe how it looked then, because maybe net benefit. I also agreed with your point on your last slide about we maybe need to focus on the end point, the implementation, and in a way the metrics that we discussed earlier are kind of further away from that, aren't they? So the prediction error, the net benefit is a combination of calibration and discrimination and gets a bit closer to what we ultimately want, which is benefit for the patient. So I wonder, how it would look, your curves for groups in terms of decision curves, and ultimately whether you could incorporate some kind of health economics to help decide whether this bias is important or not, or whether there's still actual benefit in terms of one, net benefit. So there's bias, but does it actually hurt? So are we still seeing net benefit overall, and are we still seeing cost effectiveness for the system? You see what I mean? I don't know if any of that helped or made sense.
No, that all made sense. That's really helpful. Yeah, I completely agree. I think decision curve analyses would be quite informative. Although on the spot, I'm trying to think about, what we would expect to see given the results we've seen so far. I guess if it's not obvious to me, it's probably more, imperative that we do the work. So yeah, thanks. I think that would be something good to look into. And yeah, I agree on the health economics front as well. There's a great paper from James McCabe's group at King's showing that, even kind of a quite poor performing model can lead to substantial cost savings just because of the net benefit above kind of usual routine clinical practice.
Yeah.
I've left your first point to last. I think it's the most complicated one. I'm not trying to avoid it, I promise. So yeah, I completely agree. I mean, I think, we're advised to kind of steer away from thresholding in many ways. And I think to some degree we are, I think in routine clinical practice, they are kind of used even, implicitly, they will be used to some degree, even if we're not recommending a specific threshold to use. I think, as you suggest, one way around this is to just, have more kind of patient involvement in shared decision making to kind of choose whether it's kind of a substantial risk or not. I think one potential issue with that is kind of again, it's use case dependent. So, what is the outcome of the decision? If it's, accessing a kind of a youth-friendly, kind of non-stigmatizing CBT when you're stuck on a waiting list, people are going to be more inclined to say, yeah, please send me over. If it's getting, some kind of drug treatment with really bad side effects, then people are going to be less keen. And maybe, that's part of the consideration that should be made. But I think, trying to maybe inform clinicians about the biases inherent within the models to kind of inform these discussions, I think would be quite important, because then maybe that discussion can be more tailored, and the data can be useful in that context. But agree that maybe the kind of end result should just be kind of an individual threshold kind of in discussion between clinician and patient.
Thanks, Ben. Dom.
Thanks so much.
Thank you so much, Joy, for the question and for the final comment, Dominic. I think it's very appropriate for closing the seminar today. Is this intersection between. Also, we are discussing about algorithmic bias, but it's not only about the algorithm. We are in a multi-agent system. We have your algorithm, we have the setting bias, we have the human bias as well, and of course involving clinicians, healthcare professionals, and patients into the loop is absolutely key on this to define this threshold and the rest of things related with bias. So I totally agree. I really enjoyed your talk. Thanks very much, Dominic. And I also think it was great to have you with us. And thanks everyone for joining today as well, and for having made this discussion so rich today. So thank you. Next month, we will have another machine learning and prediction modeling seminar. And that's everything. Thanks very much, and enjoy the rest of your evening. Thank you.
Thanks so much, everyone.
Thank you. Dominic, would you mind to share a copy of your slides, maybe? I would like to get the references as well, where that my work is very close to yours as well, and I found it very nice. It would be great. Thank you so much. Thanks, everyone.
Thank you, everyone.
Thank you.